I'm going to turn the mic over to Dr. Gallahan, who will be providing us with our CME today as our faculty development speaker.
All right, good morning, everybody. And I'm gonna go ahead and share my screen here and make sure this is working. Is everybody able to see that okay? See a thumbs up from Dr. Simonson, which is a good sign. Well, I'm excited to talk with everyone today about a topic I've been looking forward to bringing forward for a while, and that is diagnosing and remediating clinical reasoning difficulties amongst our learners. As we think about clinical reasoning, it is really at the core of what we do as physicians. And so hopefully the things that we talk about today will resonate with you, and we'll give you a few practical things and ways to approach these problems when they come up with the learners that you're working with. I do want to acknowledge that the content of this presentation is largely borrowed from a submission that was on MedEd Portal. If anyone is not familiar with MedEd Portal, it's a great resource for finding curriculum and pieces that can help you with designing educational interventions. It's free access. You just have to sign up for a membership through the UNMC. So the things that we're specifically going to talk about this morning are talking a little bit about cognitive theory and the underpinnings of clinical reasoning, defining what the clinical reasoning terminology is so that we're using shared language, talking about some common cognitive biases, and then we'll finish up by talking about 5 domains of clinical reasoning difficulties that our learners face and some strategies we can use to address those issues. Some of you might be familiar with a book by Daniel Kahneman called Thinking Fast and Thinking Slow, and it's a great example of stepping back and thinking about the way that we approach problems and decision making. And the basis of that book, to distill it down really simply, is that there are 2 systems. One is the fast system, that's the intuitive system, almost the unconscious thinking process. And a lot of that will resonate with you in terms of how the experienced clinician approaches problems. The other system is the slow system. It's the analytical system. It's the more measured approach that takes some time to get through. So how do doctors think? And people have studied this quite a bit. So one approach is to use an exhaustive method. And that's gathering every bit of information, making sure you don't miss anything. And that might ring a bell with our students who are first becoming clerks in their 3rd year, who take 2 hours to do an H&P. Another approach is hypothesis generation. And this is kind of an intermediary step where we kind of gather some information and propose an explanatory hypothesis and then see how it fits. Then we revise as we go along. And then the 3rd way, and again, this is as we're talking about more experienced clinicians, is based on pattern recognition. You know it when you see it. You've seen this before. You have a good repository of experience to draw upon. In reality, all of us do all of these things every time we approach a clinical problem. And system 1 and system 2 thinking, that fast and slow thinking, really is a part of all 3 of those approaches. So when we think about our early learners, and again, thinking about our 3rd year students who are just finishing up with their preclinical education, they often will have a very linear approach. So they'll start with a patient complaint, come up with a differential diagnosis for that problem, and then hopefully something that's more specific to the patient, and then come down to a working diagnosis, and finally reach a final diagnosis. Whereas when we think about our more experienced clinicians, it's more of an iterative cycle. So you might start with that chief complaint, and then your data gathering process is going to really direct the way it's going to be directed by that chief complaint and a little more focused. And we'll use something called illness scripts, which we'll talk about in a minute here. And so it's not a linear process. It's kind of a process that jumps a little bit more and evolves with incoming information. And so when we think about teaching clinical reasoning to our early learners, our goals are often to be a little bit more refined with their data gathering, organizing information and interpreting that information in a meaningful and correct way, and trying to get to that more iterative approach as opposed to a really linear, rigid approach to data gathering, and then coming up with a working diagnosis ultimately. And so if we break that process down a little bit, there are some subcomponents. I won't go through all of these, but I want to point out the ones in blue here, which are coming up with a problem representation, generating a differential diagnosis, prioritizing that differential, and then eventually coming up with a working diagnosis. And so I'm going to use a case example. I'm a neonatologist, so it's going to be a newborn with respiratory distress. And so you get that stem. Some of the questions that hopefully our learners are thinking about, or if they're not, you can ask them are, number one, how sick is the patient? What are some causes of newborn respiratory distress? Which of those causes of distress is likely in this case, and which is not as likely but important not to miss? And so we'll keep that quick example in mind as we go through these next 4 points. And these are really the key steps in the clinical reasoning process that you can focus in on with your learners. So the first one is organizing knowledge and interpreting clinical information. So what are the key features from the history and physical exam? So things that might be important that you can focus on with your learners are things like time course, demographics like age and other risk factors, general appearance on exam and key imaging findings, and really getting them to recognize pertinent positives and negatives. So if we go back to our case example, using that approach, we can get a little bit more information. And now we have an infant born at 32 weeks gestation in the setting of preterm labor. There's no steroid administration before delivery, and we have a chest x-ray that demonstrates symmetrical ground glass opacities. And I know all the neonatologists and hopefully everybody else has a good idea about what I'm talking about now. And so as we start to get those additional qualifiers and identifying and differentiating key features, in the learner's mind, hopefully what they're doing is pulling out those key features and finding the things that make each of those diagnoses that they're coming up with in a list unique and set them apart. But there are also some pieces that are maybe differentiating but don't completely eliminate other options. And so helping them recognize those places of overlap and places of uniqueness between the different diagnoses and how that fits with the information they have is a really key component here. So the next step we'll talk about is data synthesis and problem representation development. So that sounds like a lot of gobbledygook problem representation, but really what we mean here is distilling those things that are important, the key components of clinical information, down into something that is a summary of that. And so we might take our demographics, key features of the history, those key physical exam findings, and then diagnostic tests, and come up with a statement, sometimes referred to as a summary statement, that really distills that down into a sentence or two. And so going back to our example again, we start out with a really simple statement, which is an infant with respiratory distress. And then next iteration, we've added a little bit of descriptors. So what are the key pieces of history? We know this is a 32-week infant that sets that apart a little bit, that's born with respiratory distress in the setting of preterm labor without steroids. And then finally, as we get to a more comprehensive summary of all that information together, we've got even more information. I won't read that all aloud, but now we're incorporating the imaging findings and the physical exam findings as well into a comprehensive summary statement. And it turns out that creating a summary statement or that distilling down of information is a really key part of clinical reasoning. It guides hypothesis generation and development of the differential diagnosis. It requires deliberate practice, so you have to work on this to get good at it. And that problem representation really should include epidemiology, key findings, and important qualifying adjectives as well. And people refer to that as semantic qualifiers. So things like acute versus chronic, dull versus sharp when you're talking about pain. And so when we get down to the ends and get to our final summary statement, now we've got a 32 weeks gestation newborn infant born in the setting of preterm labor without prenatal steroids with acute respiratory distress, including severe tachypnea, grunting, retractions, and diffuse hazy opacities on chest x-ray. And so the learner that can put that statement out there as opposed to just we have a baby that's in respiratory distress really is summarizing and synthesizing a lot of information, and that sets them up for success as they're going on to the next steps in clinical reasoning. And studies show that students who can do this are much quicker and more comprehensive at creating a good differential diagnosis and then prioritizing that differential diagnosis as well. So our next step that we'll talk about is illness scripts and that differential diagnosis formation itself. So what is an illness script? Some of you might be familiar with this term, but an illness script simply means the mental representation that we have of particular disease processes or problems. We actually teach our students, not on our clerkship specifically, but preclinically, they get taught about creating illness scripts now. So they're creating this library of different things that are represented mentally. And so when you create these illness scripts, you're really over time refining them, making them more complete, more comprehensive. And this is something that is more experienced clinicians that we're continuing to add to our library of illness scripts and the depth of those scripts over time. And so an illness script can be really important because it's the way that you have that pattern recognition. So you can pair that problem representation against the illness script, and that's where your differential diagnosis comes from. And as we prioritize our differential diagnosis, we see how well those two things fit, that illness script and that problem representation or summary statement. And then you can start to prioritize your list. The things that fit really well float to the top. The things that don't fit as well don't float to the top. And eventually, going through that process, what we want to get to is this working diagnosis, or the thing that really guides what we're doing for patient care. So, what do we think is most likely? We may not know completely what the final diagnosis is, but this kind of is our guide star that helps us make our path forward. And so finally, the last step is awareness of cognitive biases. We could give an hour lecture on cognitive biases. We're not going to do that obviously this morning, but 3 common ones that we think about are anchoring bias, where there's a tendency to latch onto the first symptom or finding and really not let go of that. Availability bias, where we're talking about a recent case exposure that you've had, a case that you've worked on, and you see that once, and then the next time around, if you have some symptoms that overlap, that's the first thing that pops into your head. And then ascertainment or stereotype bias, where we have a tendency to let one stereotype explain a symptom. So in our case, we could say preterm infants get RDS, and we're presented with a preterm infant with distress, this baby must have RDS, and not seeing that there can be other things that cause similar symptoms. And so how do we prevent those cognitive biases? Well, we might ask our learners, what else could this be? Does anything about this not fit the story that you gave me? Or could there be more than one thing happening with the patient that explains the constellation of things that we're seeing? So ultimately, we put all this information together, and it gives us a way to look at how the learner is doing with this process. And then if we're seeing problems, we can remediate. And so the last part of the presentation I'm going to give this morning is thinking about 5 domains of clinical reasoning difficulties. The first domain would be difficulty generating that hypothesis. And this might be, you might resonate with you learners that conduct a really rigid history and physical. These are learners that check everything off on the checkbox in a very stereotypical manner, but the information is often, in details that don't really matter, that aren't important. They get through the whole process, but it might take them, again, 2 hours to do that H&P. So one way that we can help these students with remediation is using a differential diagnosis formation tool. So, and that's a long way of saying you can have them take a systems-based approach or a pathophysiology-based approach to generating their differentials. So if you have abdominal pain, for example, you might talk about things that are related to the GI system or the GU system. The second area would be premature closure. And this is where the learner might only seek data that confirms their leading hypothesis. So you get, again, kind of focused in on one thing, and you miss the opportunity to gather other information. One way to help the learner that is having this problem is to do a table comparison where you put the differential diagnosis items at the top of the table, at the top of columns, and then you can put some distinguishing features across the rows below that and have them fill in that box and come back and talk about the things that distinguish those different items on the differential diagnosis. A third item would be learners who have difficulty prioritizing. So how many of you have had a learner who just lets the patient take off and go on tangents and go down crazy rabbit holes? I know all of us have seen that. For this learner, you can have them start by justifying their differential diagnosis. So you might have them start with a summary statement. That really gives them an anchor that helps them focus as they're going through their differential diagnosis. And then have them talk about the things that fit and don't fit with that differential diagnosis with the history that they've gathered. That can really center them and help them prioritize the things that they're talking about. The next item would be those that have difficulty with synthesizing or seeing the big picture. And in this case, the learner doesn't really even form that summative statement for the case. So in this case, you might have the learner deliberately go through and make a bullet point of the key features of the case that they just presented. And then that can be used to create that summary statement. So it gets them to the point where they synthesize that information together when they're not recognizing those key components that would make up that summary statement that's so important in differential diagnosis generation. And then the last area of struggle for some of our learners is coming up with a management plan. And this is something that is more germane, particularly when we get into the residency years where the focus is more on the assessment and the plan part. And so for these learners, often they'll have a plan that is stereotypical or inappropriate. There might be a knee-jerk response to what to do with the patient just based on a specific complaint, but not based on the details of the case. So for that learner, you might have them form a management plan that can be used again by highlighting through the key components of the case and the things that are important not to miss, the things that make this case unique and not just the stereotypical case that fits a pattern. So that's a whirlwind tour of clinical reasoning and ways we can approach this. And so just to conclude here, I want to mention that problems with clinical reasoning are really common amongst our learners, and this is part of the process of becoming a physician. And these are things that we all are continuing to evolve on as we become more experienced and go through our careers as well. Recognizing these problems and pinpointing the things that are specifically causing them can really help with remediation and really help your learners make leaps forward in terms of their clinical reasoning and their sophistication as healthcare providers as well. And hopefully by taking some of these things into account, we really can recognize where the problems are and address them specifically and help our learners all on their path to better competency. So I will provide these slides after the conference this morning for reference if anyone has questions. We'll put this recording up too, but please shoot me an email if you have questions about clinical reasoning and how we can help our learners with this. But thanks for the time this morning.
Thank you, Nate. That was really interesting. I love these kind of metacognition types of thinking about thinking. And so I think if we take these tips to heart, that'll really help us as we're dealing with learners really across the continuum, and even for ourselves when we find ourselves with a puzzling case. So I really appreciate that update today.